members nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
In order to prevent the spread of the virus, we all need to do our part. One of the easiest ways to prevent that is by wearing a mask. In order for a mask to do its job, it needs to cover your nose, your mouth, and your chin. First, you should wash your hands with either sanitizer or soap and water before putting on a mask. Then pick up your mask by one of the ear loops to make sure that there's no tears or stains on the mask. If it is dirty, throw it away immediately. If it's intact, take both loops and put it over your ears like this, and then press down on the bridge of the nose to make sure that it fits and there are no gaps. Once you are done with the mask, please take it off the same way. Both ear loops, pull it away, and put it either in a Ziploc bag or throw it away if it's a surgical mask. If it's a cloth mask, make sure to wash it with soap and water and keep it dry for the next use. Do not put your mask down at your chin or above on your forehead when you're starting to remove it, as that just contaminates the mask. Thank you so much for doing your part to prevent the spread throughout the state.
Children, they are our greatest blessing, our greatest resource, and they are our future. When they have significant health problems, however, it's a tremendous strain that is placed on each and every family. Fortunately, however, we have come a long way in treatment of children specifically with heart disease, and that's what we're going to be talking about tonight. In fact, the vast majority of these pediatric patients do quite well. We're going to talk about heart valve problems, holes in the heart, extra blood vessels, and eliminating some serious heart rhythm issues. During the next hour, we have experts answering your questions about pediatric cardiology. Also, not to delay your care in this time of COVID. When somebody needs help, you got to get them help, and it is safe to go to the hospital to do that. As you know, this is a live show, so stay with us and think of some questions of your own that you'd like to call us with this evening. The number is 881-0013. Again, 881-0013. This evening's program is underwritten by the El Paso Children's Hospital. And we also want to thank Texas Tech Paul L. Foster School of Medicine for providing the medical students to man our phones. This evening, we have Sam Farsi. And Sam, you're on the air. Smile, say hey. He's already given us pins. He's helped us out. He's come back here, and he's sporting a great haircut. So Sam, thank you so much ahead of time for getting all the questions our way. We really, really appreciate that. And the El Paso County Medical Society, who has been knee-deep in providing PPE to so many different medical institutions and doctors' offices all around El Paso over the last 12 months. So thank you so much, the El Paso County Medical Society. I'm Catherine Berg, and you're watching the El Paso Physician. Thanks again for joining us. You saw a video with Dr. Days earlier who was talking about still wearing your mask. We are not out of the woods yet, and that's something that I have been told to really stress. Vaccines are coming. They're not all here yet, and I know there's major frustration in trying to get the vaccine, but I'm going to tell you a couple of places several times throughout the show that you can go to register for the vaccine. We are still in phase 1, A and B. I'm registered. I'm in phase 20,000. I'm 53 with no underlying conditions, but I am registered, and that is what matters. So for you to register for the vaccine, whether you're in the phase that is getting it right now or not, register for it so when your time comes and your turn comes, you'll be in the system. On the website to go to would be EP for El Paso, the word COVID, vaccine.com. So epcovidvaccine.com. The beautiful thing is once you go to that website, right on the front page, it will say register for COVID vaccine. It's right there, super easy, and then it walks you through what to do. If you are a person that rather use a telephone, the number is 915-212-1032. Again, 915-212-1032. So get registered. Help is on the way, but keep your masks on. Still do everything that you've been doing, social distancing. There are some people that are vaccinated, and that's great, but it doesn't mean that they cannot spread COVID if they've been in contact with someone who has had it. So a big thing. I know you're hearing it all over the news, but sometimes when it's on a medical show, it kind of checks off that mark. With us this evening, we have two pediatric cardiologists. We have Dr. Rini Sahiwala. Hello. And we also have Dr. Surya Gorla, and both of them, we've been talking really nicely here for the last, 20 minutes or so. So there's all kinds of questions that we already know to ask. The first thing is, and as you guys know that watch the show, we always talk about you're a pediatric cardiologist, you're a pediatric cardiology. What does that mean? So both y'all work with Texas Tech Children's Hospital, and I just kind of ask people to give what you do all day, every day is usually the phrase that I use. That way people at home kind of get to know what you do, and then the questions kind of come, but they just kind of get to meet you, if that makes sense. Dr. Gorla, would you like to go first?
Sure. So hi, this is Sudhir Gorla. I'm a board-certified pediatric cardiologist working as an assistant professor, Department of Pediatrics, Texas Tech University, Health Sciences Center, El Paso. And I do my clinics with El Paso Children's Hospital, and my daily routine includes taking care of kids with simple to complex congenital heart disease, and also includes most common clinical presentations like heart murmur, chest pain, palpitations, and syncope. So those include most of my daily work, and I do sometimes do fetal echocardiograms, which include diagnosing the fetus or the baby with complex heart defects during the pregnancy itself, so that we can better prepare for the delivery and so on. That's kind of my pretty much routine, I would say.
Okay. That makes sense. And if he just stole your thunder and you do the exact same, you can say ditto and we can move on, but I'd rather you didn't. So in general, same things that you do too. Anything that you'd like to add to your daily routine?
Well, Catherine, pretty much pediatric cardiologist takes care of kids with heart problems. Now, if I were to talk in detail about it, it's a vast field. However, I can say that we take care of heart problems which can be acquired or which can be congenital. Congenital heart problems are heart problems that a kid or a baby is born with. Now, these can be small holes in the heart which just produce heart murmurs, versus a very complex heart disease where, say, an entire part of the heart is missing. A chamber is missing or a whole artery is missing, and those kids kind of require more complex surgeries.
Goodness, yes.
On the other hand, we also deal with acquired heart problems, that is, any cardiomyopathies, which are heart muscle problems, sometimes secondary to viral infections or other infections that affect the heart. And we also deal with arrhythmias, which, you know, are heart rhythm problems. So that's kind of the cardiology part. If we look at symptoms, we treat kids who have chest pain, who have palpitations, who have syncope, or who come with heart murmurs.
I've got so many questions, it's not even funny. And the nice thing is, it kind of surrounds exactly what you guys already have talked about. Some people on the show know my whole history, know everybody in my family's history. My son has syncope. There was an event, we'll talk about that later, because there was a lot of children, once I knew that, there's like, oh, my son's got that, my daughter's got that, that happened to my kid. So we'll talk a little bit about that too. What I'd like to do, Dr. Gorla, is talk about the word murmur, because I feel like it's such a generic word for what's happening, but what could lie within the word murmur. Sometimes people get freaked out, it's a murmur, but sometimes it's nothing. But
So heart murmur is very much like an extra sound that we hear when we examine the patients that come to our clinic or any physician's clinic, right? So this is what I explain to my families. Heart murmur is just like a fever. If you go to any physician's office for fever, so you don't come out by the diagnosis with fever, right? You come out whether you have ear infection as an explanation for fever, or you have infection in the lung or sore throat that causes the fever, right? Similarly, what we deal with is, yes, there is a heart murmur. The question is, what is the heart murmur due to? Heart murmur is just like a symptom, and the diagnosis is the reason why you have the heart murmur. It can be due to holes in the heart, it can be due to leakage of the valves itself, or it can be due to the valves becoming narrower and causing some problems with the way the blood is exiting the heart. So the murmur is very, very generic. There are 100 different reasons why the kids can have heart murmur. The most important thing that you have to come out after coming out of your cardiology clinic is the reason for the heart murmur. That is the most important thing.
so here in Dr. Sahiwala, I'm going to ask you the most common reason that there's a murmur. What would that be? Or maybe the most common two or so, would you say?
Right. So as Dr. Gorla mentioned, murmur is a symptom or a sign that you have. It's an extra heart sound. I would say there are two main heart sounds, lub and dub. Lub and Dub, Lub
I'm
Dub.
glad that you're bringing this up because that is so easy for the audience to understand. It's easier for me to understand when you say that. So in those terms, talk about the Lub Dub.
Yes.
Lub Dub. Lub Dub.
So if you hear with a stethoscope, you will hear Lub Dub, Lub Dub, Lub Dub. A murmur is essentially something like Lub sh Dub, Lub sh Dub, Lub sh Dub. So that's the extra hard sound that is causing a murmur. I mean, that's it is called a murmur. So murmur can be the most common kind of murmurs that we see in the pediatric age group are called innocent murmurs. So they are there. We sometimes don't know why they are there. There are some theories which say that the circulation is hyperdynamic, they are growing heart, so you hear the heart sounds very well, and you hear those innocent murmurs. In our cardiology terms, we call it vibratory murmurs or soft murmurs. And those are the most common kind of murmurs that we see.
Okay.
But yes, we do get referrals for them, but then it becomes our job to kind of distinguish whether they are innocent or they are not innocent. So,
and then once somebody has because I am a Lub sh Dub, I'm one of those girls, and have been all my life, and not until I was in my early 20s that I found out that Lub sh Dub was a mitral valve that wasn't closing all the way and regurgitation, all that stuff. But my doctor said way back then, it's chronic, but it's benign. You'll have it for the rest of your life, but it's benign, which was a beautiful thing. Are there some... Let's talk about valve issues, since that was something that was brought up. Say it is a valve in a child. Again, I was in my 20s when I was technically diagnosed. If it's a valve issue, when might that occur? Like, does that happen? I would, in my head, I feel like newborns wouldn't really have a valve issue. It would be more once they start growing and tissues stretch and all that stuff. I don't know.
Okay.
But when might that start occurring?
That's a very good question, Catherine. So valve problems can be different in different age group. Again, there are a lot of heart valves, but let's talk about, there are actually 4 main heart valves, okay? The heart valves between the atrium and the ventricles, and then there are 2 heart valves which are between the ventricles and the large vessels that come out of the heart. So basically, tricuspid valve, mitral valve, aortic valve, and the pulmonary valve.
Right.
Now, as babies, we can see critical heart valve conditions which they are born with. So babies do have heart valve problems.
Interesting, okay.
So they can be born with a disease in which, say, a heart valve is completely tight and it doesn't open.
Ooh.
So if the pulmonary valve is tight and it doesn't open, we call it pulmonary stenosis. And those babies are born very, very sick. The job of the pulmonary valve is to let the blood go from the right ventricle to the lungs.
Right. Okay.
So when the blood doesn't go, those babies are sick, they are blue, so those are...
So how is that diagnosed, is my first question. Like how, so a baby's brand newly born, and I've been watching, The Midwife and all these other shows, all the stuff about babies, and how do you know? Yeah, that to me is the hardest thing. Brand new, they can't tell you what's wrong. How does a doctor start diagnosing immediately? And you may not have the answer to this, I get it, but I'm just kind of curious as you're saying that.
Right. Now, that again is a spectrum. So that starts with actually diagnosing in utero, which we call fetal echocardiogram, which is basically the ultrasound that you get done when you are pregnant, but especially we are trained to look at the heart.
Gotcha.
So we can see those severe valve conditions in which the valves are thick, they look really ugly. We can see them when the patients are in utero and tell the parents to be prepared about them.
Nice.
The other way we see them is if the kid is born and is sick, and then we kind of diagnose them when they are in the neonatal intensive care unit by echocardiograms. If they are not that severe immediately, but they became severe, say, at a couple months of age or something like that, then the pediatrician hears a loud murmur. Now, that is the loud murmur that the pediatrician hears.
Gotcha.
And then we do an echocardiogram to diagnose those kind of heart conditions.
Gotcha. Beautifully explained. Okay. So I'm going to, let's go to holes in the heart, because even in the 1950s, there are movies when people say, oh, the baby was born with a hole in his heart. And you think, well, how does that happen? So you get the hole in the heart question. Dr. Gorla, so is there a specific place in the heart that usually happens? And how is that treated upon birth? Or is that something you can also see maybe in vitro? Yeah. So go ahead and
So actually, just as Dr. Savala mentioned, heart has 4 chambers, 2 upper chambers and 2 lower chambers. Upper chambers are called atria, and the lower chambers are called ventricles. Two upper chambers or atria are separated by a wall called atrial septum. And the two lower chambers are called ventricles, and the wall separating the lower chambers is called ventricular septum. If you have a hole in the atrial septum, it's called atrial septal defect, which is a hole between the two upper chambers. If you have a hole between the two lower chambers...
So it's not quite, it hasn't formed itself, so in pregnancy, has the heart not formed itself completely? Is that what the physiological way of describing it would be?
That's correct, yes, exactly. So there is an incomplete development of the heart, we call that as. That means the muscle or the parts of the heart have not developed completely to close off all the parts of the heart. That's how you have the hole. But there are certain types of holes which are normal, unnecessary for the babies to be able to survive when they're inside the mom. Because the babies are not breathing and mom is breathing for the baby, there is no reason for the blood to go into the lungs, right? So that's why there is a hole between the two upper chambers, which is normal for every single baby that is born. That's a different type of hole.
Did not know that. Okay.
Yep. I mean, it's not typically a hole. It's called Foramen Ovale. That's a natural, normal finding. And the function of that opening is to get the blood from the right upper chamber to the left upper chamber, because the blood doesn't need to go into the lungs when the baby is inside the mom. After the baby is born, because now the baby is breathing and everything, we have some physiological changes we call. We have some changes in the pressures in the heart that will cause this Foramen Ovale to close. It's technically not a hole, but that's how something it is expressed in the normal terminology, and that will close after the baby is born. That's a normal finding for every...
How interesting is that? So the baby's born, the body knows, now I'm breathing for myself. The heart knows, now baby's breathing for himself, and we need to start closing these up. This is just a biological, physiological thing that our crazy cool bodies can do.
That's correct, exactly.
Amazing. I did not realize that.
Yeah. Okay. And if you have any hole between any upper chamber, between the upper chambers, which is called atrial septal defect, most of the times kids are asymptomatic and they will not have any significant problems. And if they have a hole between the two lower chambers, that's when the babies can get into trouble when they are so little. Mostly around 2 months of age, that's when they become symptomatic. They'll be breathing very, very fast, and they will not be able to eat very well. Because they are breathing fast and not eating very well, they will lose weight or they cannot gain weight. We call that as failure to thrive in our terminology. And that's a classic presentation of a bigger hole between the lower chambers, which is called ventricular septal defect.
Okay. So let's say now a baby does have the specific hole that you were talking about. I know that you guys aren't surgeons, but how is that then fixed? And let's say, I know that there are some things you can do when the fetus is still inside the body, but is that something you have to do once the fetus is born?
Yes.
Okay.
So the timing of the surgery, right? So if you have a bigger size hole, then the baby needs a surgery to fix the hole. The most important question is, when is the right time to do the surgery?
Right.
We want to do it at the time when the complications of doing the surgery are minimal. At the same time, you're not exposed to a lot of complications because of having the hole itself, you know.
Right.
And for the holes in the heart, which is a ventricular septal defect or a hole between two lower chambers, the ideal time is around 6 months.
Oh, interesting. Okay.
But as I mentioned before, these babies will get into trouble around 2 months of age itself. So then that's where our role comes in, and our role is to get this baby without getting into significant problems, which is like not able to gain weight, not feeding very well, breathing very fast, those kind of symptoms. We want to relieve those symptoms and let the baby gain weight and grow until 6 months, which is the ideal time to get the surgery done.
Okay, so here's the question. How do you relieve the symptoms in those very critical 6 months?
So there are some medications called Lasix, which is the most commonly used medication. That's a diuretic.
Okay.
What it does is it just gets rid of extra amount of blood that is, or water that is present in the body.
Okay.
So what the body does is, because there's a hole in the heart, kidneys knows there is a hole in the heart, and it starts to retain a lot of fluid. And this medication will get rid of extra amount of fluid that is retained by the body because of the hole in the heart. That's number one. So if the baby improves on that medication, great. If he or she continues to have the symptoms, then we will add the second medication, which is called enalapril or lisinopril. It's called ACE inhibitors pretty much.
Okay.
What it does is it will decrease the amount of blood that is being shunted through this hole.
Interesting.
Those are two commonly used medications.
And there's a medication that can do that.
That's correct. These medications will not close the hole. These will just reduce the symptoms, which are breathing fast, not able to feed very well, and having problems with the weight gain.
Right.
They will help with the symptoms, but they will not cure the hole itself.
Right.
So when the time is right, that's when we send them for the surgery around 6 months.
That makes perfect sense. You want to make sure the baby's strong enough and weighs enough, is in the best condition as possible to come out of that surgery.
That's right,
with great
yes.
health. Dr. Sahiwala, we talked a little bit before the show started. I know I said it wrong and you're smiling at me. Dr. Sahiwala. Aha, Dr. Sahiwala. When we were talking before the show, you were saying that sometimes a baby is born and seems to be fine. Mom and dad take the baby home. About 3, 4, 5 days later, there's just something wrong. And you were talking about some symptoms and some things to look for when there's a brand new baby because if you're a first-time parent, number one, they cough funny, you're freaking out. But what is it that you were referring to when we were talking about? And when should you bring the baby in or call the dog and say, you know what, this is what's going on, is this okay?
Well, so talking about congenital heart disease. So we know that congenital heart disease occurs in about 1 in 100 babies. So 1% is the incidence.
Okay.
And out of that 1%, about a quarter, which is about 25%, is called critical congenital heart disease.
Okay.
Critical congenital heart disease is that kind of a heart disease that requires some sort of an intervention or a surgery in the first month of life. So babies, when they are in utero, have a different circulation than when they come out or after, they are in the real world. So there are certain things like, so there is a heart vessel in between the lung artery and the body artery, which plays a very important role. So with some critical heart conditions, this heart vessel, which is called the PDA, stays open. And the PDA actually closes, I would say, between like 3 to 7 days of life, it starts closing. So
and that's natural?
Then
Just
that's
in a
natural.
Normal birth?
Normal birth,
Okay.
yes.
Okay.
So sometimes it closes early as well, and sometimes it could be a week later. So as long as this PDA stays open, the babies do well. So when they are discharged from the hospital at about 48 hours of life and the PDA was still open, sometimes they may not come with symptoms because, the narrowing of that part of the heart was not that bad and they were still getting good blood flow.
Okay.
But say you went for your newborn check at 7 days of life, and then you're like suddenly, okay, the pediatrician sees that, oh, I cannot feel the pulses, or I hear a murmur, or this baby doesn't quite look right. Or maybe you delayed the first visit to the pediatrician for some reason, you were yourself recovering, and you just found at home that, well, my baby is not drinking right. She used to drink about 2 ounces, and today she is huffing and puffing. She's not herself. She's sleepy. She looks purple. And, and those can happen around that part of life. So mostly you have that newborn visit with your pediatrician, pediatrician assesses, but sometimes, yes, you do have those symptoms at home. And that can sometimes be a cause of a congenital heart disease.
So I feel like this is a perfect point. Dr. Gorla, let's talk to you really quick, because let's say, you were talking about case studies earlier, say a mom just gave birth 4 days ago and something's not looking right, but it's not quite at the 7th day when he's supposed to be at the doctor. It's COVID. Do I go to the emergency room? Do I go to the doctor? What do I do? So this is the chance to say, hey, if something's wrong with the baby, definitely go. Do not delay care. This is your turn to say what's happening at the hospital right now. Say somebody comes to the emergency room. They've got a baby that just, maybe the lips are a little bit blue. They're huffing and puffing. The idea is to let people know, yes, definitely do go seek care. Take it from there.
Absolutely, Catherine. That's a very good important point, So we have seen a lot of patients, like let's say a simple appendicitis, right? So normally if you have any abdominal pain, you go to the ER, get diagnosed with the appendicitis, and you get taken care of it immediately. No big deal, right? So lately with the COVID, what we are seeing is that a lot of patients who are having some symptoms are choosing not to come.
Right.
So for the fear of getting exposed to COVID, whatnot, everything, right? So because of that, a simple problem is becoming more complicated problems. For example, let's say the example of appendicitis. So if you don't take care of the appendicitis at the right time, then you get the pus around it, and it spreads to all of the stomach, bowel, and everything, which is a nasty problem to have. And I'm sure that the family would have gone to the ER much earlier, not for the COVID, you know.
Right, right.
So we're seeing a lot of those. So what I urge everybody watching the show is, if you have any concern, any problem, please go to the physician. Please do go to the emergency room if needed, because there are a lot of things which can get complicated and can turn out to be life-threatening when things can be very simply taken care of.
Right.
We are doing everything that we can do in the hospitals. Every person entering and leaving the hospital will be screened for temperature, will be screened for any symptoms of COVID infection and any potential exposure, and they will be quarantined appropriately. And good thing is, most of the healthcare physicians or healthcare providers are vaccinated already.
Exactly.
So the chances of we passing on the infection is very, very, very minimal. And we're trying our best to prevent the exposure from one patient to other patient by maintaining the isolation, social distancing, using appropriate PPEs and everything. So I want to assure everybody watching this show that it is completely safe to go to the hospital, and it is important to go to the hospital when you're concerned about, and please don't delay the care, because that can land us in much difficult situation.
Absolutely, and I'm so glad that you said that. And we've said on this program several times, the safest place that you can be is going to the hospital, because everyone is really, really taking precautions. And again, we're doing cardiology, and cardiology is one of those things you don't want to mess with it, because time is of the essence. You don't want to lose heart muscle. And this is, I know we're talking about pediatric cardiology, but we're talking about all cardiology right now. So if you feel like you're having a stroke, I know this is pediatric, but stroke symptoms, what would they be? So someone's starting to slur a little bit, they're feeling a little droopy. A lot of times the other person that they're with, if they're with someone, will notice it more than the person that they are having themselves. Heart attack, either one of you, what are heart attack symptoms?
Chest pain.
Chest pain, what else? Left, I always think left arm.
Difficulty breathing, dyspnea.
Okay, shorter breath, feeling kind of nauseous, just knowing that, there's an elephant jumping on your chest, that's what you feel like. Don't mess with it. Yes, it's COVID. Call 911. It's worth it. It's absolutely worth it. You talked a little bit about extra blood vessels. And I know that that's a thing, but I don't know a lot about it. And I feel like that happens, or we notice it with little ones first, because by the time you're of age, you've been around and you know your symptoms. But extra blood vessels at the time of birth, or just in general with children, what are the symptoms? How do you know that they're there, and how is it treated?
Okay, so why do extra blood vessels exist? So let's come to that point first.
It's an excellent question. Why do they exist?
Yes,
right.
So like I said before, the fetus, or when the baby is in utero, has a different circulation than what you have it after you come in the real world. Because the mom essentially breathes for the baby is not breathing, so it is the mom's oxygen that goes to the baby. That is why the baby has, or I would say the fetus, has a couple extra holes or connections within the heart, so that mom's oxygen can actually reach the baby, and the baby can grow well in utero. So the extra vessel that we talk about is called ductus arteriosus, which means it's a small artery in between the pulmonary artery, that is the artery that goes to the lung, and the aorta, which is the artery that goes to the body.
Okay.
So nature has a very nice way to, kind of take care of stuff.
Right.
So after these babies are born, in the first 48 hours of life, this ductus arteriosus starts closing on its own. And by the time a baby is a couple to 2 weeks old, it's mostly kind of closed. Now, if this fails to close, then we call it patent ductus arteriosus.
You call it what?
Patent ductus arteriosus, or PDA. That means the ductus is still patent, it hasn't closed.
Okay, PDA.
Yes. So PDA is very commonly seen in preterm babies.
Oh, okay.
Yes.
So you can see it then already.
Yes.
The doctor's already looking for that.
Yes.
Okay.
And sometimes we do see them in normal term healthy babies as well. Especially for the preterm babies, they use medications, And a very commonly, you will be surprised that the over-the-counter medications like ibuprofen and Tylenol are actually very commonly used in babies to close these blood vessels, because there are some mechanisms by which they cause some changes within these vessels to close them.
Okay, you lost me, but I think this is a beautiful thing. So we have a pregnant mom, and through a sonogram, her doctor can see that the baby has extra blood vessels. They need to be closed up somehow, some way. So there are some over-counter medications the mom can take. Am I hearing this right?
No, so this is different. So
Okay.
It's normal for that extra blood vessel to be present when the baby is in utero.
Okay.
It is abnormal.
So we're talking about having that closed once baby is born and has to start breathing on its own, that we were talking about earlier.
Exactly. We don't want that vessel to close when the mom has the baby, because that's the way the oxygen is reaching the baby.
Right.
In fact, we see moms who for some reason took high doses of NSAIDs or ibuprofen, and those babies are very sick because their vessel closed when they were in the womb.
Goodness gracious.
Yes,
okay.
we do come across those cases.
I don't think that's commonly known.
It's not very common, but once in a while we get to see, and those are the parents who have like arthritis and lupus and those kind of problems that they need to take the pain medications. And that's why they say that pain medications are not particularly good for you when you are pregnant, especially in higher doses.
Interesting. Okay.
So once these babies are born, they are, and I'm talking about preterm babies now, they are watched very closely in the neonatal intensive care units.
Right.
But if the patent ductus arteriosus stays large and it doesn't show any natural signs of getting smaller or closing, then these babies are sick. So they have trouble breathing, they have a lot of fluids in their lungs, and they also come up with problems like problems in their intestines. They don't get enough blood in the lower part of their body. And then
how soon after birth, even if they're preemie, how soon do these start presenting?
I would say maybe a couple weeks. Yeah.
But we're still talking, they're in the neonatal unit, so we've got people watching.
People watching you, yes. And then in the neonatal intensive care units, the intensivist uses those medications. If those medications do not help, then there are ways to close them. Nowadays, cardiac catheterization is used very, very commonly. So they enter the baby's heart via a small needle in the thigh. They put a tube, go to the vessel, and there are little tiny plugs available, and they can plug those blood vessels. There are also surgical techniques that can be used, and these are relatively simpler surgical techniques. But again, cardiac catheterization has become very, very common.
I would love to, and I know it's too late today, but I would love to see some kind of a video or a graphic next time you guys are here of how that is done. Because I'm thinking some preemies are, 2 pounds, just a, little tiny Cornish hen, and how, to me, it's fascinating that you can get something that small and that thin up to a little tiny baby heart and fix that. And it's kind of like an ablation. You just close that vessel or close those vessels, right?
Close it with like a plug.
With
like
a little
small
plug.
Little plugs,
That is amazing to me. I mean, just the micronism or micro parts of that. You had something to add?
Yeah, that procedure that Dr. Sahavali just mentioned, cardiac cath, is being done in babies as small as 1 pound now. But again, it is done in very special and research-oriented stuff right now. It is not something commonly used, but we are advancing so much that a 1 pound baby can get it done by a cath, and there is no need for any surgical procedure. So that's the beauty of cardiac catheterization.
So I'm thinking of like a sewing needle size, or maybe even a little bit bigger. I mean, of how tiny that must be. Here's a question, just pediatric-wise. Every couple of years, I feel like we now have a little bit more chances for a baby to live. And I think years ago, it was like once they hit 22 weeks, they'll be okay. And then once they hit 21 weeks, they're going to be okay. What is that threshold today? I mean, I don't know. I feel like 20 years ago would have been so many weeks, but there's, like you said, there's so many advances going on right now and so many ways of helping brand new babies. At what week point is kind of like, okay, if you have to deliver, you have to deliver. And I'm throwing out to either one of you.
When I was training, which is not too long ago, if there was a baby that was delivered who is like a pound or so, we were saying, hey, this baby is not going to make it. We were counseling the family in such a way, hey, we might not have anything to offer for the baby. But nowadays, a 400-grammer is being resuscitated appropriately and the babies are surviving. So we have come a long way, and things are going to be much different and much advanced few years from now. So as of now, I think even a 400-grammer baby is being resuscitated, and we are doing everything for those babies, and they're doing pretty good. Some of them are doing very well, actually.
That is amazing to me. Absolutely amazing.
And that's not just applies to the premature baby as a neonatology, as just the neonatology. We have come a long way in pediatric cardiology as well.
You know, you say that. So let's, you know how I was talking about before the show, if there might be some case studies or just some patients that you've known through the years, throw a story my way that amazed you that, hey, this child is not only surviving, but thriving. Just in your experience, and I'll ask you the exact same questions, because those stories are so neat to hear, because you're hearing what the treatment is, what the situation with the child was, and what the treatment is, and how they're doing today.
You know, that's a very good point, and that's something I need to share, Catherine. I've never seen so many complicated patients all during my training until I came to El Paso. I've seen much more complex patients and complicated patients here. You know, so something that comes to my mind is a baby who is 1 month old and who was supposed to be diagnosed with a complex congenital heart disease, and the baby was born. Nowadays, we have multiple layers of screening protocols, and in reality, this baby should not have been discharged from the hospital without diagnosing. So unfortunately, the baby was discharged and came to us around 1 month of age, and the baby has something called coarctation of the aorta, which is obstruction to the blood vessel that takes blood to the body.
Obstruction, so there's something in the way, there's a blockage.
Yeah, that's correct. So the vessel that is taking blood to the body is narrowed such that the blood is not going to the lower part of the body. And generally, these babies will get surgery within 10 days to 14 days. Within 2 weeks, they will be surgically corrected. Here comes a baby at 1 month just being diagnosed with the heart defect now. You can understand and assume how bad the heart was when they came to us. The left lower chamber, which pumps the blood to the body, is barely pumping, was very, very, very sick. And fortunately, we did everything we can do for the baby. We intubated the baby immediately, putting the breathing tube and taking over the breathing of the baby. And we started some special medicine to open the extra vessel that Dr. Sahabwala was mentioning, which is the ductus arteriosus. We did everything that we can do, and then we send this patient to a surgical center. Unfortunately, we can't do those surgeries in El Paso as of now, so the baby was shipped out to a surgical center. Over there, normally, the baby will go to the surgery directly, but they have to do many other maneuvers and procedures on this baby before they can get the patient or baby fit for the surgery.
Right.
Unfortunately, he did great, and he did turn around, and he's doing great right now. And the left lower chamber, which was barely squeezing, is completely back to normal. I'm amazed how these kids do.
Right.
That's something which comes to my mind when you bring up the topic.
Oh, you know, those are stories. I like the stories where you can sigh a nice relief when it's all over. Might you have a story similar? And then I'm going to ask you about transfers, because you brought that up a little bit, but we're going to talk about that in just a moment too. But just, you know, an oh wow moment, you know, being a doctor now and thinking, I don't know if this is going to work, and it does. I love hearing those stories. I think the audience likes hearing those stories. What might have happened in your career so far?
So I cannot forget the day when it was almost, I was on my first or second day of my job in El Paso. And we had a baby who was about 29 weeks, born at 29 weeks.
Okay.
Hardly weighed 600 grams. And he was born with a disease, what we call tricuspid atresia. And in tricuspid atresia, basically your right side of the heart doesn't develop. So you are basically thriving on just the left side of the heart.
Okay.
And the right side is very, very small. And eventually, they have a stage surgery where we do stage 1, stage 2, and the third stage where we kind of are able to not repair, but we call palliate them in a way that they can just live with one ventricle or one pumping chamber of the heart. So
live with one pumping chamber. Is
chamber
this
of
for
the
a
heart.
small amount of time, or is this
Throughout their life.
Throughout their life.
Yes, and that's the heart plumbing is done in such a way that you just live with one ventricle, that is one pumping chamber of the heart. That is how much science has progressed and technology has progressed. Well, this baby was 600 grams old, 600 grams weighing, and so you can just imagine how little his heart was if he was just by the size of my arm.
Right.
So, but with the good care in the NICU, we were able to grow this baby and set him for the stage 1 surgery. And he is now 2.5 years old, and he is going to get his 3rd stage surgery. He got stage 1 and 2.
Okay.
His 3rd stage surgery maybe in the next couple years, and he's thriving excellent.
So he's 2.5 now. He was 600 grams at the time. His 3rd stage surgery then will be doing what to him physiologically to the heart?
Well, if I talk about the technical stages, what they are going to do is they route the blue blood. So basically, the blue blood, the blue blood comes into the right side of the heart, and the red blood goes from the left side of the heart, and the right ventricle pumps the blood into the lungs. So what the surgeons do, I call them the plumbers of the heart. So they route the blue blood in such a way that they bypass the right pumping chamber, and they connect the veins directly to the blood vessel in the lungs. And that way you are bypassing the right chamber, so the blood passively flows to the lungs, and the blood then comes to the left side, and then actively the heart pumps it to the rest of your body.
And this is the way that 2.5-year-old heart is going to work for the rest of his life and be fine.
Yes.
Medicine, research, it's amazing. Dr. Gorla, we had talked, and we are in a unique situation in El Paso. Both of you guys have referred to that in several situations. And before the program, we were talking about sometimes you will get a call from EMS, and literally it's a patient that is on the border. The parents from Juarez have brought the baby to the border. From there, the Border Patrol calls EMS in El Paso. And so talk about the complications of the transferring there. Of course, there's documents and this and that and the other. But the reason they're coming to the border is that they don't have the right functioning equipment, systems, hospitals, whatever situations in Juarez to do that. So it's a situation that Juarez just can't handle whatever needs to be done. When is that a situation, and how is that played out?
So let me tell you about one of the patients that I recently came across in the emergency room, Catherine. So I just mentioned about fetal echocardiography being part of my routine, in which we diagnose the babies with complex heart defects before they are born during the pregnancy, 2nd trimester of the pregnancy to be specific, okay? So I had a baby that I saw recently who was diagnosed with a major heart defect during the pregnancy itself in Juarez. That means the reason for doing this one is to have this baby delivered in such a center where he can get the appropriate care and so on. Now we have a fetus who is diagnosed with a complex heart defect that requires surgical intervention within the first few days of life. And the baby gets delivered over there because of immigration-related situations. The baby was not able to be transferred over back to us until 3rd week of life, meaning 21 days the baby was there in Juarez without getting any treatment. And there's a life-threatening medication called prostaglandin, which keeps that extra vessel that Dr. Sahavala mentioned again open to help with the circulation and everything. So by the time this baby came to us, he was not started on the medicine because it is not available on the other side of the border, unfortunately. And by the time he came to us, that medicine doesn't work. So now this is a situation where you know what to do, but unfortunately hands are tied that we can't do anything, you know. That's one of the common things that we face. The other common problem that we face with this kind of transfers is most of the times these babies are transferred in an ambulance to the border, and from the border security personnel call the 911, and the first responders are the people who are updating or giving information to the emergency room to get prepared for the baby. So we have such a narrow window to prepare for the baby. So if we get a call much earlier from the physician over there in Juarez, we will be well prepared and well equipped to take care of these kind of complex patients. And lack of the life-saving medication is one of the biggest problem that I see on a routine basis in our practice over here. So I don't know if Dr. Sahiwala has anything to add.
That's pretty much true.
Yeah.
This come in late stages when, our hands are kind of
Right.
tied.
And that's such a unique situation to, where we live because, again, our sister city, and it just depends on what hospital has, like you said, certain centers that can handle certain types of issues. Thanks for talking about that and explaining that.
Another thing is, that the time from the delivery to the time of the surgery is another important thing that we consider in the field of pediatric cardiology. Now these patients are shuttling between like multiple different hospitals, They're born in Juarez,
Right.
coming to El Paso Children's Hospital. We don't do surgeries over here. We are transferring this patient again back to another surgical center, which adds the time before the baby can get the right care that the baby is required, So those are many other minor factors that come into play, which kind of affect the quality of the care that these kids are getting. And unfortunately, majority of those things are beyond our control.
Right.
And we do our best to work with the resources that we have and do the best that we can do for the kids.
Right. Right. I want to kind of switch over. We've only got about 12 minutes or so, but I want to talk about, we talked a little bit before the show, Dr. Sahiwala, about COVID and the heart in kids. And there's something very specific that you called MISC, which is multisystematic oh my gosh, I can't speak tonight, inflammatory syndrome in children. And you were talking about what to look for. So again, sometimes young ones, if they're just sick, you think maybe they have a cold, maybe it's COVID, you don't know, there's tests, there's this and that and the other. But talk about what we were talking about prior to the show. What is there to look for? So let's say we know that someone who is 3 or 4 was diagnosed with COVID. What is it that affects their little systems compared to grown-ups? I mean, it's an inflammatory type of a virus, and you can take it from there.
Right. Thank you, Catherine, for bringing up that topic. So, as we all know, that the disease severity of COVID is lesser in kids as compared to adults. So kids will have COVID and sometimes they might just have a little fever or sometimes they may not have anything because we believe that their immune systems are robust and they kind of fight that infection pretty well. But in some kids what happens is that a few weeks after they got COVID, their immune system reacts in a way that it becomes exaggerated immune response, which affects their internal organs. So it can affect their kidneys, their heart, their liver, and does all sorts of things to them. So we have seen this a lot, and it is called the multisystemic inflammatory syndrome seen in children secondary to COVID-19. Now, I would say to parents to look out for, if your child had COVID, or had an exposure to COVID, and now you are 3 to 4 weeks out, and your child has prolonged fever, more than a day, or bilateral conjunctivitis, that is pink eyes, some weird rashes that you are like, I don't know what this is. And again, very commonly we have seen in kids, they have abdominal symptoms, that is they will have pain, like they will complain of abdominal pain, they will have some unexplained diarrhea, and they just look fatigued. The little ones, 3 or 4 years old, are crying, but they are crying a lot, so they are very, very irritable.
Again, just not themselves.
Just not themselves, and then again, fever is very, very important. So these kids, I would say, please come to the ER, please don't delay the care. And in these kids, we see that the heart gets involved as a part of the multisystemic involvement.
I see.
So in these kids, they can have the heart muscle can become weak, what we call myocarditis or myocardial dysfunction, and they need IV medications for these.
Okay.
Most of the time, we have to admit them in the ICU. They can come in a state of shock where their blood pressure is super, super low. But once we give these medications, we have seen very good results.
Okay.
And another thing that happens to them is their heart arteries, what we call the coronary arteries, become swollen and they become what we call aneurysmic. So aneurysmal, the coronary aneurysms. And again, we have to have these kids on blood thinners and give them IV medications to reverse it. Once we take care of them, we send them home after the acute phase subsides, but then it is very important for them to keep seeing us in the clinic where we continue to monitor their coronary arteries.
So let's bring this point back home. If a parent notices this, should they call 911?
Yes.
Should they go to the hospital? It's best to call 911 in this situation,
Yes,
correct?
in this situation, yes, unless you have an access to your pediatrician, where you can, you know that your pediatrician is available, it is business hours. So I would say call your pediatrician, tell that, hey, this has happened,
This is an
and
emergency,
your pediatrician
and use
can,
the words emergency.
Exactly. But if your child is appearing fatigued, doesn't have any energy, then maybe it is late and maybe the heart has already started getting involved. So I would call 911 in that case.
And again, we stress that because the important thing is not to delay your care. We have a question here from the audience. Dr. Gorla, I'm going to ask this one of you. Question from John. Hi, John. Thanks for watching. In the 1950s and 60s, there was a condition called blue babies. And he wants to know what that referred to. And again, it's not receiving blood, et cetera. But he wants to know what is the underlying pathology behind this condition. And again, many of us who are lay people, what we know about medicine is what we see on TV shows. So that's what I'm asking about. So blue babies, what does that refer to?
So there are different types of congenital heart disease, Catherine. They're classified into acyanotic and cyanotic. Acyanotic means the babies are not blue, and cyanotic means babies are blue. In cyanotic congenital heart disease, what happens is normally your blood is supposed to go, the blue blood comes to the right upper chamber, goes to the right lower chamber, and from there it goes into the lungs through the pulmonary artery, great vessel coming out of the right lower chamber. Takes oxygen, turns red in color, and comes back into the left upper chamber, left lower chamber, and then goes into the body. So that means the body is getting the oxygenated blood. In blue babies, what happens is because there are types of the heart defects, multiple different types of the heart defects, where the blue blood is not going into the lungs, rather than going into the lungs, it is going into the body. Because the deoxygenated blood, we call blue blood, is going into the body, the baby appears to be having something called cyanosis, bluish discoloration. And again, here I want to point out that the bluish discoloration of the fingers and the toes is normal in newborn babies. That is called acrocyanosis. What we are looking for is a bluish discoloration of the lips. If you have the bluish discoloration of the lips in the baby, you need to go to the emergency room directly. So historically, any baby who is having the mixing of the blood or the blue blood going into the body are typically referred to as blue babies. And among all these various types of cyanotic congenital heart disease, there is one entity called Tetralogy of Fallow. This is a type of heart defect where, again, the blue blood goes into the body and the baby can be blue. And these babies, these specific babies, can survive until 3 to 4 years of age without the surgical intervention.
Oh, goodness. Okay.
Even they don't get any surgery, they will survive until 3 to 4 years of age. Historically, those babies were typically called as blue babies.
So if a child made it to 2 or 3, 4 years of age, so I'm thinking about the discoloration with the blue blood. How would a parent not know to take that child to get checked out, to be seen, if there's a way to fix it, et cetera? I know you're talking about the lips being blue, that's one thing to look at. And I remember when my babies were born, the feet especially looked blue to me. And I'm like, is the circulation okay? Because it's a phenomenon to people, again, lay people, that there is blue blood and red blood. I mean, it's like, what does that even mean? In fact, quickly talk about blue blood and red blood.
In hindsight, it's 20/20 always, right? So historically, these babies were blue, and no one knows the significance of the lips being the blue, you know? So and these kids, as these babies got bigger and became 2 to 3 years of age, they became more symptomatic because they're running around right now and they're doing more exercise. That's when they start to have some problems.
I see.
And that's what prompted the doctor's visit, and that's what prompted this type of heart defect to be diagnosed. And that's when they found this baby is having heart defect.
So that's why
now they look back.
Okay.
Now they look back and say, hey, this baby was having some bluish discoloration of the lips from the beginning, which was a sign for us to take into consideration. So because we learn from our experiences, you know. So we didn't know initially that bluish discoloration of the lips is important. As we evolved, as we learned more about the heart defects, we came to know, hey, that is not normal. That is a sign of a complex heart defect, and that's how we learn. We learn from our mistakes, right?
Absolutely. Yeah.
So that's how we know now any bluish discoloration of the lips is not all good.
Gotcha. I would like to talk a little bit, Dr. Sahiwala, about syncope. And I know we don't have a lot of time, but I want to get it in there. Describe or maybe define syncope, because that's one of those two that you know, there's so many different ideas about that.
So syncope historically was actually derived from a Greek word. And the Greek word was called syncopein. And that was to cut short.
I see. It's kind of like when you're doing a drum beat.
Exactly.
You know, it's a little syncope, right?
So syncope basically means loss of consciousness followed by loss of muscle tone.
Okay. And that is a heart condition, because what is happening in the heart when that's going on?
Great question. So syncope can be due to a wide variety of causes. We call it non-cardiogenic causes. That means the reason is not the heart, although the heart responds in a certain way to it. And the other is cardiogenic causes. Now, cardiogenic causes can be a wide variety.
Right.
But the most common cause of syncope that we see in our day-to-day lives as pediatric cardiologists is the neurocardiogenic syncope, which means it is an interplay between the nerves and the heart.
Exactly.
So
okay.
or you may even hear the word called autonomic dysfunction, vasovagal syncope, neurocardiogenic syncope. So that is the most common. So in which what happens is your brain doesn't get enough oxygen, and so your blood pressure drops,
right,
and your heart reacts by increasing its heart rate. So this is a very vague description of what I kind of try to describe in what the stages of syncope is.
Spot on. And the reason I'm talking about that, and I know we're running out of time, is he's 18 now, but my 17-year-old, that's how it was described to me when we went to the hospital. I got that call, the ambulance is coming for your son. He, you know, passed out at school. I'm like, what happened? But that's exactly what it was. So we're looking at heart issues, but now it's also a nerve heart situation. And we are in the middle of trying to figure out what happened.
Right.
How do we prevent it going forward?
Right.
What does he look out for? What is when he's feeling a certain way?
Yes.
And on that note, what is it that people are looking for of how they're feeling? Super quick. Like, do they start feeling dizzy?
So it comes in 3 stages.
Okay.
So number 1, you start feeling prodrome, which we say you start feeling dizzy, you start having a blurred vision, or as if you were having a tunneled vision. Some of my kids say that they had ringing in their ears, weird noises, nausea.
We call it surfing the wave.
Exactly.
Right. Okay.
And then in the next stage, your blood pressure kind of starts dropping, and then you lose consciousness.
Right.
So I always tell and teenagers are very, very common presenting this, and I always tell them to watch out for these symptoms. And if you have these, please lay down to prevent fall.
Get out of the way of any hard surfaces.
Yes.
We are running out of time. Again, epcovidvaccine.com to get registered for the vaccine, the number 212-1032. You have been watching the El Paso Physician. I want to say thank you very much to Sam, who's been answering the phones, and thank you so much to our doctors. I'm Catherine Berg, and thank you so much for watching the El Paso Physician. Good evening.
Text PBS to my PBS for reminders and exclusive offers.